Hello everyone, welcome back to my YouTube channel. So today we'll be discussing the chapter Demography and Family Planning. So demography basically deals with these three main components: changes in population size, composition of the population, and distribution of the population in space. And there are five demographic processes that are defined: fertility, mortality, marriage, migration, and social mobility. We then move on to discuss the demographic cycle, which is the phases that a population goes through. So it's very important, frequently asked in exams with diagram as well. So there are five stages. There's the high stationary, early expanding, late expanding, low stationary, and declining phase. The graph is not given in the textbook, but it's very important. So I would suggest to search it elsewhere and refer for the same. So world population trends, there are a bunch of tables given. You can skip that if you want. And then a short note on birth and death rates and what is the growth rate. It's basically the crude birth rate minus the crude death rate. So there's another table of population growth rating that's given. If you want, you can study that. It's not essential. Coming to the demographic trends in India, we learn about the various demographic indicators, which are broadly divided into population statistics and vital statistics. Population statistics refer to age and sex ratios, dependency ratios, population density, etc. Vital statistics deal with vital events like birth, death, fertility, and life expectancy, etc. There's another table showing the age and sex composition of India. Then we move on to the population or age and sex pyramid, which we have been seeing since probably 9th grade geography textbooks. So we see what's the sex ratio, and state-wise, Kerala has the highest and Uttarakhand has the lowest for now, as of 2020 to 2021. There are a few other small subheadings like density of population, urbanization, family size, in which net reproductive ratio and total fertility rate are discussed, and literacy, in which crude literacy rate and effective literacy rate are discussed, and then life expectancy. The next important subtopic is fertility. We first start with the factors affecting fertility, like age at marriage, duration of married life, spacing of children, education, economic status, caste and religion, nutrition, family planning, and other factors. Then we discuss few fertility related statistics, starting with the simplest of all, birth rate, which is the number of live births in a year by the mid-year population in 2000. Then we discuss the general fertility rate, also known as GFR, which is the number of live births in a year by the mid-year female population aged 15 to 44 years in 2000. Then we discuss the general marital fertility rate, which is basically GFR, but you only consider married females in the denominator. Then you have the age-specific fertility rate, which is number of live births for mothers in a particular age group divided by the mid-year female population of the same age group in 2000. Then similarly, we have age-specific marital fertility rates using the similar logic as general marital fertility rate. Then you have the total fertility rate, which if your age group size is 5 years, it is 5 into sum of all the age groups from 15 to 49 years of age, the age specific fertility rates divided by 1000. If the age group size is 10 years, it's 10 into summation of 50 all age groups from 15 to 44 years of age specific fertility rate. Coming to the gross reproduction rate, it's basically total fertility rate, but only the female live births are considered, like female babies are considered. Next, we have the net reproduction rate, which is the number of daughters a newborn would bear during her lifetime, assuming fixed age-specific fertility rates and mortality rates. When it's equal to 1, it's the standard for following the two-child rule. All's good when it's equal to 1. When it's more than 1, it signifies an expanding and growing population. And when it's less than 1, it signifies that the population is declining and it's going below the replacement level. We also have a child-woman ratio. It's basically ratio of kids aged 0 to 4 years to the number of women aged 15 to 44 years. Then the pregnancy rate, that's we will count all pregnancies per median population irrespective of the outcome. Then abortion rate and ratio. In abortion rate, the denominator is 1,000 women aged 15 to 44 years, and for ratio, it's number of live births. Coming to the marriage rate, crude marriage rate has the median population has a denominator, and generalized marriage rate has the number of unmarried people aged 15 to 49 years as a denominator, and you multiply both into 1,000. The numerator is, of course, the number of marriages. Then there's another small note on fertility trends. We then examine the causes of high birth rate in India. Firstly, we start with the universality of marriage, then early marriage, early puberty, low standard of living, low literacy rates, traditional customs and habits, and absence of family planning. We also examine why the death rate is declining. It's due to the absence of natural checks, mass control of diseases, advances in medical science and better healthcare facilities, impact of national health programs, improvements in food supply, international aid, and development of social consciousness. So we then start with the next component of this chapter, that is family planning. We first see the WHO definition of family planning, another definition we want. So we see the scope of family planning services as defined by WHO, which involves proper spacing and limitation of births, advice on sterility, education for parenthood, sex education, screening for reproductive system pathology, genetic counseling, premarital consultation and examination, pregnancy tests, marriage counseling, preparing couples for the first child, services for unmarried mothers, home economics and nutrition, and adoption services. Coming to the health aspects of family planning, it broadly deals with women health, fetal health, and child health. For women health, you want to avoid unwanted pregnancies, space births properly, and time the births appropriately. And for child health, you would want to look at child mortality, ensure proper growth, development, and nutrition, and curb the spread of infectious diseases. And thus, after small note on welfare concept, we discuss the small family norm, which deals with the current themes of sons or daughters, two will do. Then second child after 3 years, and universal immunization. We then learn the definitions of eligible couple plus the eligible couple register and target couple. And then we also see the couple protection rate, which states that NRR is considered to be equal to 1 only if the couple protection rate is more than 60%. Then we see the National Population Policy 2000, and there are a bunch of goals listed. You can remember any 6 to 8 that would do for exams. And then we start looking at various methods of contraception. So first we have spacing methods, in which you have barrier methods that can be physical, chemical, or combined. Then intrauterine devices or IUDs, hormonal methods, post-conceptional, and miscellaneous methods. Terminal methods are sterilization. So coming to the physical barrier methods, we have the condom, female condom, diaphragm, and vaginal sponge. So basically, in general, each method of contraception, you should know the mechanism of contraception, its indications, contraindications, advantages, disadvantages, and if given, you can note the failure rate as well. Because sometimes in competitive exams, they do ask. So intrauterine devices can be medicated or non-medicated. Non-medicated ones are the first generation, copper medicated ones are the second generation, and hormonal medicated ones are the third generation. You should know the examples for each of them as well. So we should also know when to change an IUD and what's the requirements for an ideal IUD candidate. They should have born more than one child, no history of pelvic disease, normal menstrual cycles. They are willing to check the IUD tail. They should have access to follow-up and treatment facilities for potential complications, and they must be in a monogamous relationship. We then move on to discuss the timing of insertion. Immediate postpartum or postpubertal insertion, that's 6 to 8 weeks post delivery, will do. But the ideal time is during or within 10 days of the beginning of the menstrual cycle. Plus, of course, why follow up? One is for motivation, two is to confirm the presence of IUDs, and third is to diagnose and treat any complications that have arisen. The female must be instructed to regularly check the tail, visit the clinic on any side effects like fever, pelvic pain, or bleeding, and immediately consult the doctor if she misses a period. Now, moving on to hormonal contraceptives. So there's a categorization of gonadal steroids into synthetic estrogens and synthetic progestogens. Synthetic estrogens consist of ethinyl estradiol and mastrenol. Synthetic progestogens can be divided into three groups: pregnanes, estrogens, and gonads. The important examples are megestrol and medroxyprogesterone acetate, or MPA, for pregnanes, norethisterone for estrogens, and levonorgestrel for gonads. Now, coming to oral pills, we have combined pills, progestogen only pills, postcoital pills, once a month or long acting pills, and male pills. Mala N or Mala D, which you might have heard of, come under combined pills. There's also a table that would help you remember the same. Now, moving on to depot or slow release formulations, we have injectables, subcutaneous implants, and vaginal rings. Injectables can be either progestogen only, which include depot medroxyprogesterone acetate, norethinyl estradiol, norethindrone enanthate, NET-EN, and DMPA subcutaneous 104 mg. And you also have combined injectables. Few names are cyclofem, cycloprivera, and mesigina. Moving on to post-conceptional methods, that deals with the termination of pregnancy. You have menstrual regulation, menstrual induction, oral abortifacients, and a medical termination of pregnancy or abortion. So the hazards, complications, legalization of abortion, and the impact of liberalization. A very, very important thing to know is the MTP Act 1971 with the 2021 amendments. Moving on to miscellaneous methods, we have abstinence, coitus interruptus, the safe period in which all days of the cycle except days 10 to 8, also known as the fertile period, are safe for intercourse. Then you have the natural family planning methods, in which we see the basal body temperature, cervical mucus or Billings or ovulation method, and symptothermic method. Then we also have breastfeeding, lactational amenorrhea, and birth control vaccines. Now, moving on to terminal methods, that's sterilization. There are a few government guidelines given for sterilization, like basically the requirements for a candidate to be eligible to undergo sterilization. Then we discuss male sterilization and female sterilization separately. So we should know the procedure, the complications, causes of failure, post-op advice, and there's also a short note on no scalpel vasectomy. So female sterilization can be either laparoscopy or mini lap operations. We then move on to the evaluation of contraceptive methods, in which we learn about the Pearl Index, which counts the number of failures per 100 women years of exposure, which is basically the number of total accidental pregnancies by total months of exposure into 1200. Then there's another method that's called life table analysis. So we then move on to what are the requirements to ensure a family planning program is successful. It must be accessible, must be affordable, must be client-centered, should have evidence-based technical guidance. There must be effective communication between all parties and assure contraceptive security. There should be supportive health policies along with coordination between various agencies. There should be high-performing staff recruited. There must be an adequate budget that's used effectively. There also must be evidence-based decision making, must lead strongly and manage well, and ensure the appropriate integration of services. So we then discuss the unmet need for family planning and then the demand that has been satisfied by modern contraceptives, in which there's a mention of the National Family Health Survey or NFHS file. We also see contraception in adolescents, and then the delivery system of contraceptives at various healthcare levels like center level, state, district, community health center, public health center, and village levels. At the village level, village health guides, trained DICE, and ASHA workers are the go-to people for the same. It also discusses new initiatives like home delivery of contraceptives, ensuring spacing at birth, pregnancy test kits, that are Nishchay home-based kits, Mission Parivar Vikas, and new contraceptive launch. There's another table showing the various family planning measures that have been taken by the government. If you want, you can refer it. Otherwise, you can skip it. Then there's another small note on community needs assessment approach, the involvement of the private sector, and incentives given for family planning, like the National Family Planning Indemnity Scheme that helps provide compensation for any complications or deaths due to sterilization procedures. Then the Family Welfare Linked Health Insurance Scheme and the postpartum program and population education. Then another small note on the sociology of family planning or volunteer organizations. There's a lot of text in here, but if you ask me, no one has, it hasn't been routinely asked in exams, so you can afford to skip it if you want. Then there's the last topic, that's the evaluation of family planning, which sees the evaluation of the need, evaluation of the plans, performance, in which you assess the services, the response, cost analysis, and other activities, evaluation of the effects of the program, and impact. So that finishes this chapter. This would be very helpful for OBG and maybe even pediatrics as well. So thanks for watching this video. I hope you found it helpful. If you have any suggestions, please let me know. See you soon. Thanks for watching again.